Okay, good morning, everyone. We are here for the Wellness Nurse webinar for August, and today we're going to talk a little bit about the 1815 grant results from the last 18 months, and we'll talk a little bit about falls prevention, which is Falls Prevention Month or Week is coming up in September. We'll talk about some programming surrounding that. And then we'll have some time just for open forum to bring up anything that you want to talk about with your nurse colleagues. So I will share my slideshow here. So first, I just want to share today some of the 1815 results from our last cohort. You can see this graph shows the results for our hypertension participants that you chose starting from October 1st of 2022 through this past June of 2023. You can see this graph shows this average systolic blood pressure. So the green is the systolic blood pressure and the blue bar is the diastolic blood pressure. So the baseline prior to October 22 for your participants that you chose, the average for all of the participants was 153 for systolic, and the average diastolic was 83. So 153 over 83 was the starting average. And at the end of June, when data was pulled, those blood pressures for these participants in that cohort decreased to 137 over 76. So that is a fantastic improvement in blood pressure for these participants that you worked with. Really excellent results. You're breaking.
We can't hear you. We can't see your screen.
You can't. Okay, hold on. What did I do here? And I can't see. There we go. Is that better?
Yeah, that's
Okay,
good.
thank you. I can see both for some reason. I'm not sure why. Yeah, so you can just see these results here. So the 153 over 83, that's the beginning of the cohort. And then the ending was 137 over 76 for the average blood pressure. So at the end, we had 198 participants in the group, and 190 of those had updated blood pressures entered in PHL since October, which was amazing that the staff nurses could get that. Healthy living plans. So at the beginning of the cohort, about 33% of participants had healthy living plans entered in PHL within the last year. By the end of the cohort, that was up to 46% of your hypertension participants had a healthy living plan entered. And so the results for the diabetes cohort, the beginning of October, the baseline for A1Cs was 8%. And at the end of June, there was a decrease to 7.6% average for A1Cs, which was really good. Also, considering you could have chosen any participant with diabetes. They didn't have to have like an A1C over a certain limit. So some people actually chose participants who had a lower A1C. So really there wasn't much room for improvement. So it was good to see even this amount of decrease in the A1Cs. And so for healthy living plans, 34% of participants had a healthy living plan at the beginning of this cohort, and at the end, 62% had a healthy living plan. So that is amazing. A1Cs, of course, getting that number is a little bit harder for nurses. And so 71 out of 90 had updated A1Cs entered into PHL since October. Still really good, but obviously we can see that it's a little bit harder to obtain those lab values. And so we had a report due to the Vermont Department of Health in July. We submitted that, and part of that report, we had to do some outcome sheets based on the 1815 15 work over the past 5 years. And then I had done one for the past 18 months for this last 2 cohorts. So these outcome sheets are on STAR. If you go to STAR and you go to tools, and it's under marketing. So if you're on the marketing STAR page, you can see I have a snapshot here. If you go down to towards the bottom of the page, there'll be this flyers and handouts. And so there's 4 outcome sheets from 2023 that you can take a look at. It's pretty interesting data, I think, just showing the great work that the nurses and the coordinators do with their participants. This is one of the outcome sheets for the last 18 months that I had created for the hypertension deliverable that we had. And what I'll do is I'll actually open that up and share it with you a little bit, just so you can see a little bit of the work. Are you seeing that infographic expanded?
Mm-hmm.
Okay.
Yeah.
So interesting. This chart here shows both cohorts, so cohort 1 and cohort 2. So cohort 1 was January through September of 2022, and then cohort 2 was October to June. And you can see there was a very similar results in the average systolic blood pressure decrease. So the cohort 1 started with a systolic blood pressure of 155, ended at 137. Cohort 2 started at 153 and ended at 137. So you can see the work that you are all doing is really consistent and is carrying through from each cohort. We did do a little participant comparison. And so this next chart shows blood pressures of both the targeted group and then non-targeted participants. And you can look at this later so you can see it in more detail, but really both groups, the targeted and non-targeted, have a decrease in blood pressure, which is great. So that kind of shows that the work that you're doing with your targeted participants is really crossing over into your work with the non-targeted participants. We added a success story in here to share with Vermont Department of Health, and then just an overview of the interventions that you are all doing with your participants, just showing, the blood pressure clinics that you're doing, lending the automatic blood pressure cuffs, food support. In these 2 combined cohorts, 109 participants received food support supported by SASH staff. You can see this is based on hypertension. So as I mentioned before, 46% of cohorts had created a healthy living plan in the past year. One interesting fact, I think, is that the number of staff check-ins. So the participants in this hypertension cohorts had an average of 7.1 staff visits in each cohort, and compared to 5.4 for non-targeted participants. So you're getting out there and you're working with these participants a little bit more than you are your other participants, the non-targeted group. There were 59 referrals to smoke and cessation classes. There was 145 referrals to dental services. 638 participants attended some sort of exercise program, whether that was non-SASH or SASH hosted. 64 participants were referred to other self-management programs, and you completed 3,322 medication adherence screens. We just kind of go on to talking about the use of the hypertension protocols by the SASH coordinator and the wellness nurse, and just how you are receiving your monthly status reports as a mean of communication regarding your participants and their screenings. And then, of course, we did pull some data on not just the targeted group, but out of all of SASH. So you can see here the numbers of assistance that SASH provided those with diabetes, pre-diabetes, or were at risk of diabetes. So food assistance was 761 participants received food assistance. Foot care was provided to 55 participants. Exercise was 45 participants. And again, this just shows for the diabetes group, the targeted group received an average of 8.4 visits compared to about 6 to 5.5 visits for those with diabetes in the regular SASH group. Kind of the same results with hypertension, just showing you how many participants received food support, exercise. You loaned 28 blood pressure cuffs to participants, and then the number of referrals to self-management programs. And just a reminder that this data is really just what is entered into PHL. So I feel like, and maybe you might agree, that these numbers are probably much higher. Just, you know, getting into the routine of going to the services and referrals tab in PHL and entering in any of those services and referrals that your participants are either receiving or you're referring to those programs. I did send out a nurse survey back in June just to kind of get some feedback on the 1815 grant. And some of the biggest contributing factors that we saw for both diabetes and hypertension for management included SASH support, diet changes, PCP support, medication management, and motivation of the participant. And now that the 1815 grant was a 5-year grant, and that has ended back the end of June. And so we have started another grant with the Vermont Department of Health. We are still reviewing those deliverables, and we'll be creating a plan and the next quality initiative project. We anticipate rolling out the next cohort in the coming months, and you'll receive an email soon with what that might look like. And now I'll just kind of hop over to fall prevention. And I'm not sure how many of you have had a chance to do the training in Relias. You all should have been assigned a training called Understanding Falls in the Home. It is due, at least for the nurses. I'm not sure if coordinators were included on that also or not. That is due on the end of August. So take a look if you have not completed that. I'm not going to go into a lot of detail on what it goes over, but I do just want to kind of go over, like, what are some fall risks that you might see in the home. And let's see, you can either put information in the chat, or you can certainly just speak up on what you either see or what you know are some fall risks and that you might see in the home. Anybody have any ideas?
Hi, Marcy, this is Linda. I think some of the fall risks are like the loose carpeting that, you know, gets in the way, and participants may trip over that, or furniture that's in the way.
Yep.
Those are some medications that they take. They may get dizzy and fall from that. Uneven ground in their yard can, you know, kind of help them to fall on the ground. And I mean, those are just a few, but there's many.
Yep. Suzanne said clutter, which is a big thing. Hoarders are quite common in some of our buildings. And Jody said low light. Definitely, especially at night.
Increased alcohol consumption in older adults.
Yep, that's a good one. Yep. Medications, Esperanza said, Cheryl said, hypertension in the morning when someone's getting up. Excellent. What else? I'm gonna show you my list here that I kind of jotted down. Let me see if I can get this. Oh, and Cheryl said falling while bending over to get something off the floor. AFib. Yep. So, some of the things, yep, urinary incontinence, rushing to the bathroom, perfect. Yeah, so what I had kind of jotted down, you guys hit on you all hit on some of these, so poor vision. Making sure that your participants have regular eye checks. Blood pressure was mentioned, conditions in the home, clutter, lighting, even like weakness, balance problems, movement issues, assisted devices, as much as we think maybe that is going to help them, it can create falls for them. Chronic conditions such as arthritis, which is kind of a movement issue, stroke, Parkinson's, heart failure. So if they have any lower edema, medication side effects, polypharmacy, the more medications that they're taking, the higher risk they are for falls, dementia, dehydration, footwear. So when you're in the home, kind of, looking and seeing what your participants are wearing for footwear or what they're wearing, if they're going outside. Poor nutrition and ladders. That is one thing that really stuck out to me when I was doing wellness nursing for SASH. Is I had one participant that was using a ladder with no sort of handrails on it at all. And she definitely had some chronic conditions with limited movement and edema, and really talking about educating your participants on that sort of situation, and really emphasizing, if you can wait, definitely wait to try to get that canning jar up on the top shelf that you might not really need right away. So I'm just curious. So falls prevention is technically Falls Prevention Week is September 18th to the 22nd. Definitely doesn't have to be anything that you're doing for programming in that particular week. It can be anytime in September. It can be beyond September. I did share this link to a toolkit from the National Council on Aging that has some infographics and articles that you might want to share in your SASH Flash newsletter to participants. You could post them in your buildings. You could share them at, if you're doing an upcoming blood pressure clinic or some other programming with your participants, maybe print some of them out, or maybe you do a 5 or 10 minute talk on fall prevention. And then I also shared, all of these links will be sent out in the email after the webinar. And then I do have a link here to an article that also talked about some key points about fall prevention and like the top chronic conditions associated with falls, which are arthritis, heart disease, diabetes, just exploring the link between those chronic conditions and fall risks, and talking about engaging your participants with evidence-based programming. Within this article, they do share some flyers that might be interesting to either use during programming or to take tidbits from it to share in your SASH newsletter. And then Falls Free Vermont is a great resource. They have some other infographics and information that you can share, but they also are in charge of the Stay Steady program, which is a collaboration between physical therapist and yourself, whoever would want to coordinate this program. So what it is it's a 2-hour program featuring fall prevention tips. And then a physical therapist would actually be running this for you. And they do a risk assessment with each participant. So like a get up and go, the 10-second, you get up, you walk 10 feet, you turn around and come back. They do like sit to stand and see how many you can do of those in a minute. And I think there's one or two other assessments that they do just to kind of see what your fall risk level is and what interventions that they might recommend to your participants. I had done this with my coordinator pretty much every year when I was doing that. Every September, we would set this up. And it was really great. Participants came back with some knowledge regarding fall risk, fall hazards in the home, and then, of course, the assessment. And so if you go to Falls Free Vermont, there is on their top toolbar, you'll have to kind of scroll over, but there's the Stay Steady program on there. And what you do is, let me see, so if you see this, if you come to this page here, it'll be called site coordinator. So essentially the nurse or coordinator would be considered the site coordinator. So what you would want to do is click on host an event, and there's going to be a form that you fill out, and Falls Free Vermont will connect you with a physical therapist to be able to come and do this programming. If you think that you're going to want to do it, I would definitely do this, sign up pretty soon just to allow for scheduling time. Even if you have to host it in October or further out, I definitely think it's well worth doing that. And then other evidence-based fall programming that you might do, and maybe some panels are already doing some of these programming, such as Tai Chi, I know is really popular with SASH panels. And it's not that you have to be trained in all of these programs or have a coordinator be trained in these. You can reach out to these different areas. So like the Tai Chi Vermont website, even the local Council on Aging for the Matter of Balance program, just to see if there are any staff or any contacts that they can give you so that they can come in and do the program for you. Just because I know nurses have limited time, and same with coordinators. Jody is a Tai Chi instructor. And so Jody is going to just have you speak up a little bit and talk about kind of your experience as a Tai Chi instructor, and maybe if you have a story of like any participants, like maybe like if they improved by doing Tai Chi, or if they have ever mentioned to you, that they definitely feel like they have improved their balance, etc. And maybe just about your own experience doing Tai Chi.
Yeah, sure. Thanks, Marcy. Yeah, I've been teaching Tai Chi since I got certified in 2015, on and off. I don't do it with any regularity, but I attempt to do it at least once a year, depending on which panel I can coordinate effectively. And sometimes I'm in the community, like either a senior center, or I try to go to housing. It ends up pulling from the community, so it's not only SASH participants. Sometimes it even ends up being more community members. I've had some pretty successful classes. It is evidence-based, proven for fall reduction, mostly because it decreases pain and increases flexibility and strength. There's a lot of coordination and posture reminders. There's more mind awareness around Tai Chi to help you be more knowledgeable and mindful of your body movement through space. So it sort of helps decrease the risk of falling and increases confidence in walking overall. I found some people, it's really difficult to get people to do regular practice, which is where you get the fall prevention benefits. I don't even have a regular practice at home. So, it's difficult. There's a lot of logistics for a nurse to implement. I feel like the classes, I think Marcy's recommendation about going to Tai Chi Vermont website and see who all the instructors are and see if there's willingness to even pull from some of those people in your county, to provide a class. So yeah, like a regular practice is pretty challenging for people. I just do it once a week. I can't do it twice a week. That would be ideal, but they also need to do it at home with some regularity. So I've witnessed and heard, I've gotten some verbal reports from people about some immediate results and satisfaction just from being involved in the class. Like, I feel taller and I can straighten out and my posture is feeling support, whatever it is. And it's I'm not really getting the end of class sort of survey. Like for a while, Council on Aging were doing surveys before and after class, but they were supporting the class for a while. I think they still can in some instances, meaning, supporting you with documentation. I'm not sure if Marcy, you're aware of that support going forward for people who want to. So, some of those logistics, I think Council on Aging, the RSVP people follow up on with the participants, and they also like to see, Council on Aging in particular, across the state, like to see whoever participated in Tai Chi, if there's a willingness for those people to learn to become instructors. So I don't know how, they probably reach out. Sometimes they want the person's personal information that I've collected. Some people aren't willing to provide that, but Council on Aging makes an attempt to reach out to those students who have been in the Tai Chi classes to see if there's an interest, which is really cool. Yeah, so I just feel like, for me anyway, I'm motivated by the fall prevention month to sort of establish a class somewhere, and talk about fall prevention and sort of generate interest that way. I feel like fall and winter are better months depending on where you live, I guess, and people's willingness to drive, their proximity to the class. If it's in housing, it's one thing, right? That's pretty easy if you have a community room. But lately it's been less satisfying, I have to say. Like in the summer, post flood, I had a class that started before the flood, and then I just canceled it just because it was in Waterbury, Vermont, and it was a little too hectic for people. And then, there was the disaster relief, like support that people were in the class that we're also providing. So yeah, so I would love to do, personally, I would love to do more education and housing around fall prevention and try to really target SASH participants in particular. But there's also a need for outreach in the community to include both SASH participants and community members who attend the senior centers.
Yep, that's a good point, Jody.
Yeah.
Yep. No. One of the other programs is called Matter of Balance. And so this is a program that you would have to be trained in or reach out to Council on Aging to see if there's any instructors that could come in and do a training program for your participants. And so this is an 8-week program. It does require 2 trained instructors. It's 2 hours per week. And it's really a combination of education surrounding fall prevention, fall risks, and then at the end of each day or each time you meet, there's about a half an hour, which is dedicated to like low impact stretching movement. And really it could be some of it's seated, some of it's standing, but it can certainly be modified to just seated if you have a participant who cannot stand. So it is a great program. I am trained in it. I have done it. Usually we did it once a year in a couple different locations. And it's something that we actually had participants that would come back each year and do with us. And then Arthritis Foundation, there's one program that you can do through the Arthritis Foundation. You would have to be trained in that. Again, reaching out to the Council on Aging to see if they have any trainers that could come do a program for you. And a new one that you're gonna get more information on this fall is called Walk with Ease. So SASH received a grant from the Arthritis Foundation, which is starting October 1st. And so there'll be some more information coming out about the Walk with Ease program. And I believe that program is set up so it could be like a individual could focus on their own goals, or it can be a group program. So more to come on that. Is anybody have any, have you done any of these other programs like Matter of Balance or any program from the Arthritis Foundation? Besides Jody?
Marcy?
Yep.
I've tried to get people for Tai Chi at Kelly's Field, and I could never find anyone. The people that I contacted, I think they were from Tai Chi Vermont. They weren't available at that time, or excuse that rooster. But I just find it hard to get people that are qualified to do that.
Yeah. And so, you can, maybe if Tai Chi doesn't work for you, maybe one of these other programs reaching out might work instead.
Okay.
Yep. Anyone else?
It looks like in the chat, Jody said that someone in their, and Barry does Matter of Balance. And then it looks like Cheryl said that they do Tai Chi in their building, but it's run by a resident, not one of like the coordinators or wellness nurses.
Yeah, perfect. Kind of like what Jody was saying that, they're trying to train other people. And that's great that a resident is active and doing that. Yeah.
And then it looks like Alicia said Tai Chi is run by our site coordinator and Bone Builders is run by a resident, which is also awesome. And then
yeah, Bone Builders is really popular, it seems like.
Yeah, I think so.
Often see that held in like meal sites, the bone builder programs. Yep. And I know Annika, the training coordinator, does send information out to all staff regarding if there's a upcoming Tai Chi trainer program. So you can, if you're interested in that, you can always watch for those emails that come out. And if you are interested in any of the other programs, definitely reach out to Council on Aging. I know I was trained on Matter of Balance through Council on Aging and the Arthritis Foundation class. So, let's see. And so there are, of course, non-evidence-based programming that you can certainly do. One of this infographic here was came from Falls Free Vermont. It's exercise tips from a physical therapist. It's a brochure, like a trifold brochure. You can certainly print this out and hand out to participants who maybe want to do some stretching or exercises in the home. You could certainly take some of these and do them with a group. And there's really nothing to say that if you were to do an Arthritis Foundation class or a Matter of Balance class, you could certainly take those exercises, combine them. You just wouldn't be able to say it's an Arthritis Foundation class or a Matter of Balance class, but you could certainly take those those exercises and do just a general exercise or stretching group with your participants. Other things would be, after doing the fall screening risk on the wellness nurse assessment, looking at their risk score, maybe talking to the PCP about an evaluation for a referral to PT or OT. If a participant is, needing grab bars in their home, getting that OT referral is also a good idea. Before I move on, anything else on falls prevention, or if anybody wants to share what they've done in the past, maybe they've done a stay steady program.
Looks like Sarah in the chat said that she did an indoor walking group with falls prevention exercises that worked pretty well for her.
Yep. So Sarah, how did you do that? Did you walk, was it like walking in a mall, or was it walking within like a residential building?
Yeah, so I'm at Grand Way Commons, and there's four floors, and so we did, walked back and forth on each floor, and at the end of like the hall on each floor, there's like railings on each side, and so we can, hold on to that if they need to. And we just did basically a lot of these, not the weight one, but some of the mostly the leg exercises.
Yeah.
On each floor, and then we did each floor and then the first floor again and sit to stands, and it was like 30 minutes. So yeah, I felt like it worked out pretty well.
Yeah, that's a great idea, especially in like the winter time, or if it happens to be raining that day. Yeah.
Yeah, because that's when people are like the least active, so.
No, that's great. That's a good idea. Anyone have anything else you want to share? So the SASH annual conference, I know information went out, I believe, in our SASH beat regarding this. So we're having our annual SASH conference. It's going to be in person. So since this is going to be the first in person since COVID, so we're excited about this. So it's going to be Wednesday, the 27th at the Fireside Inn in Lebanon, New Hampshire. I believe there's going to be a registration email that's going to be sent out to all of SASH staff, either the end of this week or beginning of next week. And Casey had sent me this image of boxes, so I just want to perk your interest. What's inside is for the SASH nurses to provide to SASH participants. If you have any guesses on what might be in these boxes, you can certainly throw that in the chat. But we're hoping it's going to be a fun-filled day. It's going to be packed with presenters, and so we're hoping that everybody gets a chance to be able to make it. The assessment recently came out, and just wondering if you had any questions regarding those revisions. I think the major revision on the wellness nurse one was the change in the medication adherence screening. And then there were some minor language changes. And there was a couple questions on cannabis use that were added. And that, of course, we had our cannabis training last month with Jessalyn Nolan. She's a wellness nurse in the Chittenden area. And so just wondering if there was any questions on any of those revisions.
I have a question to that.
Sure.
I am wondering what this means in terms of the few markers that make an assessment done. Sometimes so I know the medication adherence was part of that in the past before this change. And I ask because sometimes I go in and do just that at the end of the month and able to capture the assessments for the month. And then I document the rest of the assessment later.
Okay. Are you going back to that same visit to document, or are you just creating a visit and just doing the med adherence? And then when you go back, you're creating another new visit?
No, when I go back, I go in on that same date that
Okay.
I did the assessment to complete my documentation.
I have not heard differently that that they're not using the medication adherence screen to capture assessments. I believe they still are. I can double check on that.
Okay.
So it is the annual. So the 3 questions that capture if an assessment has been completed or not is the annual visit question, the tobacco question, and then the medication adherence question. So,
I have a quick question about that also.
sure.
If one of the questions doesn't apply to our participant on that med adherence and we skip it, does it say it hasn't been completed? Do all of them have to be checked or?
No, that was brought up yesterday, so I'm gonna see if Jolyn can put like a NA. Just so like in your mind, you don't think that you forgot to enter it in. But I'm thinking, I don't know which particular question they capture for the med adherence. I'm assuming it's the first one, if you miss any medications or not. But I can check on that and see. But if you leave it blank, that's fine. For those ones, I think it's like the question number 3, where it asks if you're using one of these devices or interventions, or if you want to use one. Is that kind of what you're talking about, Alicia?
Yes, that's exactly it.
Yeah. You can leave those blank if neither apply, but I will ask Jolyn to kind of put another fill in there that's not applicable or for that. Any other questions on the assessment? So we have about 15 minutes left, and this is really time for you to be bringing up or asking anything that you want of your colleagues. If you want, I can certainly ask each one of you what's happening at your panel if you want to share. Do you have any participant situations you want to ask for input on? So you're free to just speak up.
I have a situation I could discuss if that's okay.
Yes, certainly.
We have a participant who I've only met a couple of times. I did her assessment, and besides that, she has not responded to my phone calls. She frequently changes her phone number, and she has had many episodes of paranoia where she reports to the property manager that the neighbor upstairs drills holes through her ceiling and sends dust and spitballs. And lately this weekend, she left 2 messages this morning again that the upstairs neighbor had drilled more holes and drizzled anti-itch medication all over her apartment. And now she needs to clean, and she wants to move, and she wants to take a basement apartment if nothing else is available. All of these behaviors. I've reported to PCP several times, of course, and my manager keeps forwarding me the voicemails with just more of the same, and I just don't know what to do to help this situation. Upon my conversation with her when I did her assessment, the first day I tried, she threw me out, and then she called me and asked me to come back the next day, and we did her assessment. At that point, she shared with me that she had taken pictures of the holes, and she shows me these holes that have putty in them, blah, blah, blah. And I said to her, there's no way for the property manager to prove anything. If the man upstairs, if you ask him, or if the property manager asks him to stop this behavior and he says that isn't something I'm doing, they have no way of proving it. And then you'll need to talk to the police if you insist that this is happening. And she did. She called the police. They made a report and it went all the way to court. And this other frail participant upstairs had to come to court with his case manager, and the case was dismissed.
Hmm.
So it's really spiraling out of control for this woman. Does anyone have any good ideas?
Suzanne, this is Jody.
Yeah. Hi.
Hi. If someone kind of similar, very challenging situation, to say the least. Because the person, does this person have a council on aging case manager by chance?
No, and she has really nobody. She is estranged from her family. She has a couple of friends listed that are not in state.
Yeah. Would she be, do you have a sense of her willingness to get connected to community mental health?
Last time I suggested anything in that arena, she threw me out.
I guess I would also then reach out to the CHT at her practice and see how they've addressed her delusional thinking. If there's a psych diagnosis, maybe you already have that information.
I
But
don't think there is really a community health team around her doctor's office either. It's a remote kind of doctor's office. They have never really called me back. I've just called to the triage line and reported my observations. But and she's only on a low dose antidepressant. She doesn't have any psych diagnoses that I know of.
Sounds really tough.
I know.
And she's not returning any sort of phone calls
No,
from you or
so the last thing that happened, not the last thing, but a couple of weeks ago, the executive director for whom I work, she called me to ask what to do. And, you know, they all reach out to me hoping that I can do something. I just don't know what I can offer so I called her, and there's no ability to leave a voicemail even.
yeah.
And what the director had been, the reason she called me is she had been contacted by the local physical therapy connected to our hospital, where this participant actually still does some volunteering. And they had called with concerns because the woman had left her laptop and telephone at her volunteer site, saying that there were voices there and people were calling her that she didn't want to hear from, and what to do now with these devices that were left at the physical therapy office. It's really out of control.
Suzanne, is she homebound? Obviously not. She volunteers.
No.
Sarah, you unmuted. Were you gonna say something?
Yeah, because we did have a kind of a similar situation too, where a woman who had, you know, dementia to a mild degree for years. She's actually a community participant, so not in our building, but her she started having more delusional, paranoid thoughts and behaviors, and just kept progressing. And you know, we got her power of attorney involved. And you know, I don't know if that person has that, you know, I don't know if you have on file someone who could help in that way. But we ended up, I mean, this person got so bad that she was so afraid to go to the grocery store. She wasn't eating. And we did a wellness check and decided to call because she needed a psych eval and someone to sort of evaluate her and sort of, you know, meet sort of these acute psychological needs. And she wouldn't go up there. But finally, we went over there. My SASH coordinator has known her for years in other kind of settings too. So trusted person. And we were able to call 911, and the EMS, you know, were great. And they were waited for like an hour while we tried to convince her to go up there. And finally, she did, with the SASH coordinator, you know, went up for a little bit with her. She was admitted And is still actually in the hospital awaiting placement now, but you know, it was really hard there for a while where she was very resistant, very, you know, people are out to get me, people are listening through my walls, I can't eat any of the food because it's contaminated, and, you know, all this stuff. And there was just like, we called her primary, you know, if there's any social worker at her primary, they should be, you know, able to help somewhat, do something. But,
Yeah.
you know, when they're refusing to go there, that's like, you know, I mean, it became an emergency situation where she was not safe in her home, in my situation. So
Yeah.
I don't know, I would say like power of attorney, social worker at the primary care, and if there is, or self-neglect, we did a self-neglect report also, because she
Right.
wasn't eating, because she wasn't making safe choices for herself.
Yeah.
Yeah.
Yeah. Thank you.
Yeah, just some thoughts. It's really hard,
Thanks so
I know.
much.
Sarah, I'm curious about the self-neglect report and how you feel like that plays out and its effectiveness.
It like didn't even do anything.
Yeah,
Well,
that's my concern about those
I
self-neglect.
mean, you know, we have done that for other people in our building, and it's actually helped because, you know, in the state of Vermont, they're not going to force them to do anything against their will. It's just a more, they get someone from AgeWell or the Council on Aging reaches out within 48 hours and takes it more seriously, getting them the help that they need, and sort of evaluates the situation. And that has helped with some people in the past, but in this situation, I don't know if they even, I don't know if they reached out because nothing happened with that. And, you know, maybe she didn't answer the phone, and, you know, so then they didn't do anything, you know, so it's sort of, you know, in theory, it's a good thing, but in this situation, it did not really do anything. But I do think it can be a good thing.
That's great. Thanks.
Suzanne, does she go to the PCP on a somewhat regular basis, or is she?
She has been there recently, and the problem is she has not exhibited any such behaviors during those visits. She's dealing with a leg ulcer right now, and you know, that's the reason she's been there, and that's what's been addressed, and that's all. And sometimes the coordinator I work with says that she'll walk by her in the hallway and everything is ducky, and can I do anything to support you? No, I'm fine, nothing. And
Suzanne, does the leg ulcer warrant a home health referral, or is it self-managed?
she already is seeing the wound clinic, I believe, which is practically next door to where she lives.
Convenient though.
Yeah. And again, she has not responded to my calls. So I have not been involved with the leg ulcer. I only know that from the PCP that I reported to last week.
Can you have a partners team meeting around it?
We could.
You might as well bounce it off of and pull from your partners, and
Yeah.
so it's
Yeah.
not, so you're not taking it all on. You're not responsible for this.
Yeah. I just feel a little helpless because the housing
Sure.
people keep forwarding these voicemails.
That's
and
fine. That's
it's
fine.
painful.
That's fine. You don't have to even respond to them. You know what I mean? Like, you are not personally responsible.
No.
for that outcome.
Thank you, Jody.
Yeah.
Anyone else have anything they want to either share or ask questions? Nobody has anything else. I can give you back 5 minutes in your day. I just want to thank you all for coming, and Logan will send out an email with the slides and the recording and any of the links in the next few days. All right. Thank you, everyone.
Thank
Bye.
you.